Welcome to AZENT's Guideline Updates, Episode G6, Acute Kidney Injury. I am Dr. Z, hospitalist attending, and KC is with me. Educational only, not individual medical advice.
I know AKI is everywhere on the wards. AKI on the list almost every morning. But I want to start with something you said before we recorded. The guideline situation is unusual here.
It is, and it matters. The current operative guideline is KDIGO 2012. That guideline is still official. Now, a major update, the KDIGO AKI and AKD update, was in public review draft through May 2026. As of our recording, it has not been published. So I want to be explicit. KDIGO 2012 is the guideline we practice from. We will talk about what is coming in the draft, but only as framing, not as current recommendations.
Got it. So if a patient has an AKI on the list, what is the KDIGO 2012 staging?
3 stages. Stage 1. Creatinine rise of 0.3 milligrams per deciliter or more within 48 hours, or 1.5 to 1.9 times baseline within 7 days, or urine output below 0.5 milliliters per kilogram per hour for 6 to 12 hours. Stage 2. Creatinine 2 to 2.9 times baseline, or urine output below 0.5 for 12 or more hours. Stage 3. Creatinine 3 times baseline or above 4, or initiation of dialysis, or anuria more than 12 hours, or urine output below 0.3 for more than 24 hours.
And staging matters because?
Because it drives your escalation plan. Stage 1 AKI in the right clinical context can be managed on the floor. Stage 3 AKI means nephrology consult now. Think about renal replacement therapy planning and look for life-threatening complications. Staging is not just a label. It is a decision framework.
Let us go through the management framework. What do we actually do?
5 core steps from KDIGO 2012. Step 1. Treat the underlying cause. You cannot just manage AKI in isolation. Step 2. Eliminate nephrotoxins. This is one of the most impactful things a hospitalist can do. Hold NSAIDs. Hold ACE inhibitors and ARBs in the setting of volume depletion. Monitor aminoglycosides and vancomycin carefully. Dose adjust metformin and other renally cleared medications. Step 3. Optimize hemodynamics. Target MAP above 65. Step 4. Give the right fluid. Step 5. Use diuretics only for volume overload, not as a treatment strategy for AKI itself.
What do you mean by the right fluid?
Balanced crystalloids. Lactated ringers or plasmolite preferred over normal saline. This is post-2012 evidence from the SMART trial in 2018, which showed that balanced crystalloids reduced the composite of major adverse kidney events compared to normal saline in critically ill patients. It does not change KDIGO 2012's core principles, but it operationalizes the fluid choice.
So when a patient comes in volume depleted with AKI and someone orders 2 liters of normal saline, should I be changing that?
You should be defaulting to lactated ringers or plasmolite, unless there is a specific contraindication. Large volume normal saline in AKI contributes to hyperchloremic acidosis, which can worsen tubular injury. This is not a minor nuance. It is a practice change supported by strong trial evidence.
What about the idea that we should give more fluids to an AKI patient to flush out the kidneys?
That is one of the most common misconceptions in hospital medicine. Volume resuscitation is indicated for prerenal AKI in a patient who is fluid responsive. But fluid overload is independently harmful. It worsens oxygenation, increases abdominal compartment pressure, delays kidney recovery. Do not give fluids just because the creatinine is elevated.
Let's talk about HRS-AKI, since I see a lot of liver patients.
Hepatorenal syndrome type AKI. This is a specific entity with new guidance from the AASLD in 2024. The workup starts with an albumin challenge. 1 gram per kilogram on day 1. Maximum 100 grams, continued for up to 2 days. The idea is to rule out volume responsiveness before you declare HRS. If the creatinine does not improve by more than 25% after the albumin challenge, and you have excluded other causes, that is consistent with HRS-AKI.
Then what?
Vasoconstrictors. Terlipressin is FDA approved for HRS-AKI in the U.S. now, though it has a boxed warning for respiratory failure. So careful monitoring is required, and it is not available at every institution. Norepinephrine is an alternative in the ICU setting. This is a nephrology and hepatology consult situation. Your job as the hospitalist is to recognize the pattern, start the albumin challenge, and escalate early. Do not wait until the creatinine triples before you call.
What is coming in the KDIGO draft? Even if we cannot use it yet, I want to know what to watch for.
The draft introduces the concept of AKD, acute kidney disease, as a continuum from 0 to 90 days after the AKI event. It is expected to include new biomarker roles for subclinical AKI detection, personalized map targets, updated guidance on contrast-associated AKI, and a cleaner follow-up framework. The 3-month follow-up currently in KDIGO 2012 may become more individualized and earlier in some cases.
Should I be practicing based on that draft?
Not formally, but understanding the direction of the evidence helps you reason better. The concept of AKD as a period of high risk for CKD transition is already supported by the data even before the guideline formalizes it. Patients with stage 2 or 3 AKI should have nephrology follow-up arranged, not just told to see their primary care physician in 3 months.
3 take-homes.
1. Stage the AKI on admission using KDIGO 2012 creatinine and urine output criteria. 2. Eliminate nephrotoxins systematically and use balanced crystalloids, not saline, for volume resuscitation. 3. Do not discharge a patient with significant AKI without a specific kidney follow-up plan. Not outpatient follow-up as a vague instruction. A plan.
Episode G6 done. Next is G7, DKA, and HHS. The first major update in 15 years.
It is a big one. See you in episode G7 on AZETs.